Hello, and welcome to the RadioGraphics podcast. My name is Anna Sophia McKenney. I'm a PGY5 or R4 resident in the Integrated IR-DR program at New York Presbyterian Weill Cornell Medical College in New York City. I've also had the pleasure of working as a part of the RadioGraphics Junior Editorial Board, also called the RG team, over the past few years. I'm excited to be hosting the RadioGraphics podcast today, substituting in for Dr. Gibbs and Dr. Frederick this week. And I'll be highlighting a few of the features in our October 2022 Interventional Radiology themed monograph. Today, we will be discussing the piece entitled Contemporary Management of Acute Pulmonary Embolism, Evolution of Catheter-Based Therapy. We're very lucky today to have the lead author here, Dr. Timothy Carlon, MD, MBA, who is also a PGY5R4 resident in the Integrated IR-DR program at the Icahn School of Medicine at Mount Sinai in New York City.
Hi, Sophie. I'm very happy to be here. Thank you for having me, and thank you to RadioGraphics and the whole team for helping me through this, putting together this piece and having this conversation.
Sounds great. Let's get started. So by way of introduction, all of us are familiar with pulmonary embolism. It represents the third leading cause of cardiovascular mortality and the leading cause of preventable in-hospital death. It affects an estimated 100 to 200,000 people in the United States each year. The standard management for PE is systemic anticoagulation therapy, but new studies of systemic administration of thrombolytic agents has reinforced the benefit of rapid offloading of that right ventricular strain that's caused by this entity. This is balanced, of course, by an increased risk of bleeding, and major bleeding rates have been shown to be more than 10% in some studies of thrombolytic therapy. For pathologic entities that do have a similar mechanism, such as stroke or myocardial infarction, restoring vessel patency procedurally has become standard for acute presentations. Therefore, there's an interest in bringing similar techniques to the setting of acute PE, and this goes back nearly 50 years to case studies that were published then. As a result, there are a growing number of devices to do this, and each has a slightly different mechanism. They all have the same goal, which is to remove a clot rapidly while minimizing the risk for major bleeding. Additionally, the management of pulmonary embolism can be complex, so remember that in general, the indication for intervention is going to be to relieve that right ventricular dysfunction. Also, try to keep in mind that this is really an interdisciplinary problem that requires an interdisciplinary approach, and we will discuss PE response teams today. So this piece first summarizes the classifications of PE, then several different types of endovascular treatment with examples of different types of catheters. In conjunction with this, it describes many of the studies that have been performed on these devices, which I will name here. The authors further describe their approach when working with their local PE response team, or PERT, and discuss some future directions that the field is taking. The paper itself is available online at the RadioGraphics website, and I want to highlight that it has multiple incredible cases and photographs of a bunch of the devices, which may be helpful for further understanding, so I do encourage you to seek out the original paper. So let's start talking about the classification of pulmonary embolism. So there are two major classification systems, and both of them divide PE into three major categories. There's the AHA, or American Heart Association classification, and the European Society of Cardiology, or ESC. In terms of the most severe classification, the massive by the AHA or the high risk by the ESC have a similar definition. They're both describe PE that is characterized by hypotension. These patients usually present with cardiac arrest or obstructive shock that is not caused by arrhythmia. These presentations are more rare, but they do have a notably high mortality, reported to be more than 50% at 90 days. The treatment for massive or high-risk PE is systemic thrombolysis or simply an open thrombectomy. The middle category is going to be treated a little bit differently between the AHA and ESC classifications. The submassive PE for the AHA is simply a PE that has no hypotension, but does have signs of right ventricular dysfunction. This could be defined by a right ventricular to left ventricular ratio that's greater than 0.9, either on echocardiography or on CT pulmonary angiography, an elevated BMP, that's B-type natriuretic peptide, or an elevated troponin. So the intermediate risk classification, according to the ESC, uses the PE Severity Index, or PESI. Now, this is a complex index that takes into account several demographic characteristics, comorbidities, and clinical presentation. Each factor carries different weights so that, for example, older patients and those with signs of systemic hypoperfusion will rapidly progress to a higher risk stratum. Now, the PESI class actually has an independent role where it's able to estimate all-cause mortality at 30 days, so it may be useful independent of its role in the ESC classification system. Within the intermediate risk, now there is a subdivision into high intermediate risk and low intermediate risk. In high intermediate risk, both imaging findings of right ventricular dysfunction and laboratory findings of right ventricular myocardial injury are shown, whereas in low intermediate risk, only one of the above is shown. Finally, low risk according to the AHA or ESC is simply pulmonary embolus that is hemodynamically stable, does not show imaging findings or laboratory findings of right ventricular dysfunction or injury. Another index that may be useful to reference is the BOVA score. This simply incorporates heart rate, blood pressure, troponin, and imaging signs of right ventricular dysfunction. Now, to take a pause, these scores are extremely useful, but we should keep in mind as we continue this discussion that contraindications to systemic thrombolysis and therapeutic anticoagulation may dictate some of the care for these patients. Because it limits their options, it might actually make a case for procedural intervention rather than a systemic biochemical therapy. The location of the thrombus may also be important in terms of procedural decisions, in that distal thrombi may not be accessible by catheter-directed therapies. And finally, we should always keep in mind the chronicity of the thrombus if we are able to determine it. Tim, do you want to chime in on any of that? There was a lot about, how we should classify all of these entities.
Yeah, absolutely. I think there are two things that are worth sort of highlighting here. So one is that these two classification systems are both in common use, but in general, in our practice, we rely on the ESC classification. And that's because the distinction between high intermediate and low intermediate is very, very useful in assessing who might need intervention. And so in the paper from ESC, patients who are in that high intermediate risk category, they mandate consideration of systemic or catheter-based therapy to relieve obstruction in the event that the patient should start to decompensate. Now, obviously, not everybody is a candidate for that, but it's an important distinction that's got a little bit more clarity on intervention and or thrombolysis than the AHA classification. The other thing that's worth considering here is all of the workup and this classification is about acute presentation and acute complications. The other consideration is development of chronic thromboembolic pulmonary hypertension. Obviously, that's an important consequence of acute PE, but to date, we have not shown that intervention or thrombolysis on acute PE in any study has prevented the development of CTEPH. So our thoughts regarding intervention and risk strata, at least in the acute setting, are about acute RV offloading and not the development of CTEPH.
Thank you, Tim, for that perspective. That's really, really important to keep those two things in mind. I agree. So now that we've talked a little bit about the classification of PE, let's talk about some of the treatment modalities that are highlighted in this article. So currently used devices fall into two broad categories. The first is catheter-directed thrombolytic infusion devices, and these may be with or without an additional device feature that allows for clot fragmentation. The other major group of endovascular treatment modalities is mechanical suction thrombectomy devices, which can either be used with small bore or large bore catheters. At this time, we should probably note that the final author on this paper does disclose relationships with multiple entities, including Boston Scientific, Medtronic, Philips, Innova Vascular, and Truvik Medical. And for full documentation, I encourage you to see the original paper. Let's talk a little bit about catheter-directed thrombolysis. In this situation, a thrombolytic is administered directly into the pulmonary arterial system. This has a benefit because it allows for a reduced dose of thrombolytic agent, and it's been reported that up to 1/4 of the systemic dose may be used effectively. The second, and this is the big one, is that direct infusion into the artery of interest should avoid off-target administration, as opposed to systemic administration, where, as you can imagine by its very nature, will shunt away from occluded vessels. Some of the catheters that are used in catheter-directed thrombolysis include the Cragg-McNamara and the Unifuse. These actually traverse across the clot first to allow for administration of the thrombolytic across the span of the occlusion. The Ecosonic is a type of ultrasound-facilitated catheter-directed thrombolysis, or USCDT, and this adds a high-frequency, low-power ultrasound, which causes disaggregation of the fibrin in real time and thus accelerates the delivery of thrombolytic agents into the clot. This theoretically will increase the amount of lysis that's performed. The Bashir catheter is a multi-side hole infusion catheter which has limbs that expand inside the clot. There's an image of this. It really looks like an expandable sort of basket that you can see in the paper. Several prospective studies have been performed to evaluate catheter-directed thrombolysis. The ultrasound catheter-directed thrombolysis has been tested in the Ultima trial, Seattle 2, and Optolyse. Catheter-directed thrombolysis without the ultrasound is shown in the Perfect trial, and the Sunset SPE compares the two types. Overall, the safety profile of this catheter-directed therapy appears to be non-inferior to systemic administration. The second major family of catheter-directed therapies are suction thrombectomy devices. These use manual or mechanical suction to physically aspirate the thrombus out of the vessel. The benefit of this is that there's really no need for thrombolytic agents, and as a result, you may avoid a prolonged ICU stay for monitoring. Some specific catheters include the FlowTriever, the Indigo aspiration system, the AngioVac, and the recently approved for trial use AlphaVac. Now, I will make a note that the AngioJet, which some of are familiar with for giving rheolytic therapy, that means that pulsed saline or thrombolytic agent is used, has been found to be associated with bradyarrhythmia, heart blockage, and hemodynamic collapse. So it now carries a black box warning against use in the pulmonary arteries. To talk about some of the specifics, the FlowTriever is a large bore catheter, and it's connected to a 60 ml locking syringe, which creates the vacuum. This therefore uses manual suction to engage thrombus, and you may know it from the FLAIR study. The Indigo aspiration system utilizes a smaller catheter, which is more maneuverable, but by nature of its size, might not work as well for larger clots. It does have a powered pump, and this was tested in the Extract PE trial. Finally, the AngioVac is a vena-venous bypass system. It has an expandable funnel tip, which there's also a photograph of in the paper. And it additionally has an outflow cannula to reduce blood loss, which I'll touch on in a minute. It's indicated for central venous and right atrial use, so it's really going to be useful if you have a right atrial clot that's in transit. Of note, though, while performing this, you'll usually need a perfusionist and often will need echocardiographic guidance, so that is a consideration when planning whether to use this or not. The big risks of suction thrombectomy really are that larger catheters are required on the whole than in catheter-directed thrombolysis, and therefore stiffer wires are required to steer them. This results in an increased risk of damage to the pulmonary vasculature. Additionally, passage of a large catheter through the pulmonic valve may exacerbate right ventricular dysfunction. Now, Tim, did you want to comment on this at all?
Yeah, I'll avoid going too much into the weeds here, but I'll add that anecdotally we've seen hemodynamic instability using large bore catheters in people with high pre-procedure PA systolic pressures. That said, this requires more formal study because there's obviously more at play here than just the pressure. Otherwise, we would only see this instability in people with high pressures and not in other patients, and we would see it in everybody with high pressures, which we don't see. That said, we always make sure to, as much as possible on pre-procedural echo, measure the pulmonary artery systolic pressure, and then also at the beginning of the procedure, we perform a right heart cath measuring right heart and pulmonary pressures.
In addition to the pressures, another procedural consideration is that while we're doing the suction in particular, there is a fair amount of blood loss. You can imagine you're pulling out the clot as well as the unclotted blood. So many of these devices either have a return cannula, such as in the AngioVac, which we described a minute ago, or have a formal collection and filtration system, such as the FlowTriever FlowSaver combination. Others have feedback mechanisms, which basically mean it'll only turn on the suction when a thrombus is detected, and then will turn off the suction when there's no thrombus detected. So that, in theory, will help only withdraw blood when it's absolutely necessary. And that's employed in the indigo aspiration system called the Lightning. One last consideration that we should make when using suction thrombectomy devices is that because they are in larger catheters, they require larger sheath. And the use of larger sheaths does increase the risk of complications at the access site itself. Now, Tim, we mentioned a whole bunch of different catheters. Is there anything you want to add to that discussion?
Yeah, absolutely. So there are a bunch of different devices mentioned in the paper, but just to highlight how fast this space is moving, there are, I can think of a dozen new catheters that are under investigation or very early trials, even since we sort of put this together. So just to name a few, Medtronic, Boston Scientific, Cordis, CSI, Truvic, they all have new devices that are in early stages of investigation. The important thing to realize about this is most of these are for suction thrombectomy. So our considerations, when we think about this from a general perspective, how do we interpret the preoperative imaging and how do we decide on which patients are going to be largely the same, even though the devices obviously work slightly differently and there are going to be so many. The other thing to note is that multiple of these catheters that are sort of presented in the paper as very, very early are, again, things are moving very, very fast, are already in their next stage. So the Apex AV trial, which is for the AlphaVac device, it's mentioned as, announced but not enrolling. It's now enrolling, which is very exciting, and that device is in use. And even older devices like the Unifuse catheter now carry official designations, FDA approval for use in the pulmonary arteries. So the space is moving very fast, and it's exciting for those of us who are treating PE.
Wow, yeah, that is really exciting. I agree. So the final piece that I just want to address before we move on to some of the day-to-day considerations is many of you might be thinking, how does IVC filter placement fit into all of this? IVC filter placement has been described in patients post-thrombectomy and or systemic thrombolysis, but ultimately the data is inconclusive about its benefit. There's substantial variation in all of the society guidelines, as you may already know. So therefore, filters are still typically only placed when therapeutic anticoagulation is contraindicated. Now, in this piece, the authors share their personal approach to a patient with PE. The big take-home message is that this is a multidisciplinary approach, and therefore many institutions use a PE response team, or PERT. I know my institution personally has one, and this paper gives a detailed description based on the Mount Sinai experience. Tim, do you want to tell us a little bit about what you are looking at when you meet a patient when there's a PERT activation?
Absolutely. Thanks, Sophie. Yeah, I think this really gets at the core of what we need to consider in pulmonary embolism. So in the Mount Sinai system, the start of a PE response team activation is, of course, identification of an intermediate or high-risk PE. Not everybody presenting with PE needs a multidisciplinary evaluation because, of course, patients with low-risk PE do extremely well with anticoagulation alone and are often treated even in the outpatient setting. That said, when a patient presents with intermediate high or high-risk PE, the start of the process is our PERT is notified, PERT being the acronym for PE response team. The start of the PERT process is evaluation by the Pulmonary Critical Care Consult Service. They will first assess the patient and then start a multidisciplinary discussion between the entire PERT team. Now, the structure of the PERT team is going to vary at different institutions, but at our institution, It's pulmonary critical care, interventional radiology, cardiology, cardiothoracic surgery, and vascular medicine. Everybody comes together and discusses in real time the patient. So the patient is evaluated for prognostication and risk stratification. We'll generally put their risk stratification using, as I mentioned before, the ESC classification, because that intermediate high versus intermediate low is very valuable in determining who might need intervention. So the patient has their labs drawn. We'll calculate a PE severity index and a BOVA score and the associated risk categories. The labs that we review are primarily looking for signs of systemic hypoperfusion and myocardial injury. So specifically, we'll look at their troponin and their BMP, and we'll also check lactate to assess for signs of systemic hypoperfusion. The CTA is going to be reviewed not only for clot burden, but also for clot location. So whether it's central or non-central, because that affects our ability to intervene. And then whether or not there is RV strain. So oftentimes on the CTA itself, you can see sort of dramatic signs of RV strain, so a very, very large right ventricle relative to the left, for example. At a minimum, a point of care echo will be performed either by the pulmonary critical care fellow or by the cardiology fellow. And then in most cases, we'll perform a full formal transthoracic echocardiogram. And one of the biggest benefits of that, in addition to assessing for signs of right ventricular dysfunction and McConnell sign, is we can estimate the pulmonary artery systolic pressure and the right ventricular pressures. Unless there is a very strong contraindication, so think, recent neurosurgery, active hemorrhage, intracranial hemorrhage, all patients are going to be started on systemic anticoagulation, usually with unfractionated infused heparin, sometimes with low molecular weight heparin, depending on the patient. And generally, again, unless there's a contraindication such as recent surgery, that will be started with bolus. And that sort of sets up the whole team to discuss the patient.
Great. So then once we've started that systemic anticoagulation, we start to take into consideration whether this is a high risk or an intermediate risk lesion. In the high risk situation, we really require rapid reversal of hemodynamic instability to decrease the mortality risk. So usually systemic thrombolysis will actually be the first line. However, as we've discussed, this causes a substantial bleeding risk. And so surgical or endovascular intervention is primarily going to be considered for patients with a specific contraindication to or with ultimate failure of systemic thrombolysis. In the case of intermediate risk PE, in this case, we're not so much trying to reverse the hemodynamic instability immediately, we're trying to avoid ultimate hemodynamic decompensation. In this case, the standard of care will be anticoagulation therapy and close monitoring. And in the case of any deterioration, reperfusion with systemic thrombolysis or catheter-based therapy will be used. Usually this ends up meaning that patients who are selected for endovascular therapy are in the high, intermediate, and high risk categories, and they have some kind of relative contraindication to systemic thrombolysis. In terms of choosing a technique, surgery is usually reserved for patients at high risk who can't undergo any form of thrombolysis. Suction thrombectomy is going to be especially useful if there's a central clot or a clot in transit and a special contraindication thrombolysis. However, as we've mentioned already, suction thrombectomy should be avoided in patients who have marked pulmonary hypertension. So once we're in the procedure room, Tim, how does this look?
Yeah, absolutely. And again, what we present in the paper is what the approach looks like at our institution, understanding that there are nuances that vary in different places. For example, the role of surgery depends on your local resources, as does the role of catheter-based intervention. So for us, once we're in the procedure, these devices can be used from both a femoral or a jugular approach. We almost exclusively, not entirely, you'll see some images of jugular approach in the paper, we'll use a femoral approach, and that's because we want to, as much as possible, leave the head of the bed clear for anesthesiology because, of course, these patients can decompensate rather quickly, and the role of an anesthesiologist or even a cardiac anesthesiologist becomes very important in those cases. So once we get access, we will cross the heart with a pigtail catheter. Many people will use a balloon catheter, so a Swan-Ganz, to cross the heart. Both are well described, but the important thing is you use a catheter like that to avoid damaging the valves or passing a wire behind the cords. A wire itself may not cause many issues passing behind the cords, but of course, if you're putting a 20 French device up through the heart and the wire has gone behind the cord, you could have a catastrophic complication, which could be easily avoided by sort of more properly crossing the heart. We, as I mentioned before, will measure right heart and pulmonary artery pressures both before and after the intervention. We'll also obtain a pulmonary artery blood gas or a mixed venous blood gas in order to calculate cardiac output, because what we're really worried about in these patients is hemodynamic or cardiac-based collapse, not a respiratory or hypoxic collapse, because this tends to be the issue. We will have anesthesia support for all of our cases. There are institutions that provide their own sedation or do these with no sedation, but that is not our practice. In patients who are in sort of the massive or nearly massive category, we'll ensure they have arterial access and an independent central venous access for anesthesia in case they need vasopressor administration or occasionally ionotropic administration. Generally, these cases are done under MAC or with minimal sedation. And the reason for that is these patients very, very poorly tolerate the hemodynamic changes associated with increased sedation. The mechanism of collapse is, like I said, cardiac collapse. So the changes in venous return and the changes in cardiac output that can be associated with, say, induction for general anesthesia can be catastrophic in patients who are teetering on the borderline of obstructive shock. The other thing that's kept in mind is the wires and catheters that pass through the heart during the procedure can, of course, cause arrhythmias. In particular, we can see bradyarrhythmias and right bundle branch block as we cross the pulmonary outflow tract. So we are always certain to check the pre-procedure EKG, in particular for, say, left bundle branch block, to assess for complete heart block. It is not part of our practice, but there are practices that either routinely or at least assess for placement of a transvenous pacer during the procedure in the event that that complete block is induced. But that is not a routine part of everyone's practice or our practice. The other thing to pay attention to in working with your anesthesia colleagues in these procedures is that aspiration can cause significant blood loss. So that needs to be communicated actively as you are aspirating. And if you choose to use systems that either minimize the blood loss or allow for return of aspirated products. And finally, I just want to mention the role of extracorporeal membrane oxygenation, or ECMO, very briefly. That's a complicated issue that could be an entire paper of its own, but most pulmonary embolism, even high-risk pulmonary embolism patients, do not require ECMO. But in the very high or kind of high end of high intermediate risk patients, the discussion should be held pre-procedurally about whether this patient may need ECMO and potentially the ECMO team notified in advance. In some cases, we will actually obtain an additional arterial access at the beginning of the procedure if we are particularly concerned about a patient or if the ECMO team would like to be on standby so that the access is in place should ECMO be needed. Lastly, there's the role of ICU admission. So all patients receiving catheter-directed thrombolysis, so 12 to 24 hours of infusion of thrombolytic directly into the pulmonary arteries, are admitted to the ICU at our institution and monitored there until the thrombolytic infusion is stopped. Patients who undergo an uncomplicated suction thrombectomy may be screened to a step-down unit at our institution. And then all patients who are able to will receive systemic anticoagulation post-procedurally in accordance with the guidelines. So the duration of that sort of determined by the provoking factors and the number of prior PEs, again, without going too much into the details of that.
Wow, thank you for that incredible summary of really the details of how we approach these patients. Now, to take a step back and sort of look at the bigger picture, as we've sort of alluded to already, in IR, the technology just constantly seems to outpace our ability to study it really effectively. So, as a part of that in the paper, the authors identify several different questions that really need to be answered in this section of the field. So the first is there a long-term benefit of catheter-based therapy over systemic anticoagulation for high intermediate risk PE? And then, of course, which patients with intermediate risk will require immediate intervention versus further data gathering and monitoring? What short-term endpoints will be most important to monitor in these patients? Which part structures and processes will most improve outcomes as part of that interdisciplinary team? What is the cost effectiveness going to be of these different care modalities? And will that reduced ICU or hospital stay length make up for a potentially increased cost? The paper also makes a great point to highlight so many studies that are really, really interesting and up and coming in this field. Tim, do you want to comment on any of them?
Yeah, absolutely. And I think what I most want to do at this point is add a little bit of historical perspective. So to date, there are only 2 true level 1 trials. And what I mean by that are actual prospective randomized trials where patients receive 2 competing therapies as opposed to different versions of an existing therapy. At this point, that's the Ultima trial, which compared ultrasound-facilitated catheter-directed thrombolysis to systemic anticoagulation, and the Sunset trial, which compared ultrasound-facilitated catheter-directed thrombolysis to catheter-directed thrombolysis without ultrasound facilitation. There are many, many other trials that are either retrospective or registry or single arm, but those are the true level 1 trials that we have to date. And this puts us sort of in the space that maybe stroke was 20 years ago, where we know we have these great technologies, but we haven't worked out in a truly rigorous fashion what the best way and the best use cases are for them in order to help patients most. So where we find ourselves now is there's a recognition in the field that we need to up the level of evidence. And so just to highlight a couple of the trials that are mentioned in the paper and that are coming out that meet that criteria of really being a level 1 trial. So there's the HI-PYTHO study. That's going to be ultrasound catheter-directed thrombolysis versus anticoagulation. And that's prospective, randomized, and looks at outcomes beyond just the very, very short term, did we offload the RV in the first 24 to 48 hours? But, how did these patients do longer term? There's the Peerless study, which compares a large bore suction device versus catheter-directed thrombolysis. And then there's the PE TRACT study, which is an upcoming randomized controlled trial. The protocol isn't finalized, but it's expected to reflect the current state of clinical practice and compare catheter-directed thrombolysis to anticoagulation with a true focus on the clinical outcomes, because that's ultimately what matters most to patients. So the exciting thing about so many of these studies is not only is there sort of that increased level of randomization and rigor involved, but also there's a focus on endpoints beyond that very, very short term, did we offload the RV? And that's really the direction that we want to go in this space, because we want to, like we said, make sure that we're making a clinical difference. And finally, there should be several additional studies, again, true randomized studies announced within the next year that are going to assess longer-term outcomes of these devices and several additional devices.
Wow, that's incredible. Thank you for that perspective and that kind of look to the future. It's a really exciting field and a really exciting topic. Thank you so much. Again, this is Dr. Tim Carlon from the Icahn School of Medicine at Mount Sinai, discussing his recent paper in Radiographic entitled Contemporary Management of Acute Pulmonary Embolism, Evolution of Catheter-Based Therapy. I'm Dr. Sophie McKenney from NYP Weill Cornell, and we hope that you will access this and many other resources on the RSNA Journal website, pubs.rsna.org. Thank you so much for joining us, and thank you, Tim.
Thank you, Sophie.